Welcome and let's learn how to perform objective refraction. My name is Dr. Manyara. If this is your first time here, just check our other videos in the link below. You can subscribe by hitting the subscribe button so that we alert you when we upload our next videos. In this lecture, we will define refraction in general and then talk about the different ways of doing refraction before we start on objective refraction. We will also point some of the indications and then go ahead and discuss the whole process, the whole procedure and the interpretation of results. So what is refraction? It is simply determining the refractive state of an eye in a patient you suspect to have refractive error or as a general checkup of the patient. Remember, all patients require objective refraction. We have two main types of doing this. The first is subjective refraction, and this is by subjectively determining the combination of either the spheres or the cylinders necessary to provide the best visual acuity for a patient. It means you have to rely on the patient's feedback to get the best results. So if patients are not able to give feedback, then this might not be a good idea. The second is objective refraction, which we call retinoscopy. And this is where the refractive state of the eye is determined without input from the patient. So basically, we rely on our own performance, on our own equipment. And so we should be very good at it. Ideally, we should perform this retinoscopy or objective refraction before the subjective refraction. So this should be performed first and then we do the subjective refraction. So what are some of the indications for objective refraction? I have just said that we need to perform objective refraction for all patients, but there are those particular groups of people that we have to do objective refraction because we cannot rely on them if we want to do the subjective refraction. These people include young children, those with mental disability or other disability. Again, if you have an extreme language barrier and you have no interpreter, you would consider doing objective refraction. We can also do objective refraction in malingerers just to determine if they have any vision or not. So let's go to performing the retinoscope itself. So to perform retinoscopy, we use a retinoscope which has various parts: the brow rest, the eyepiece, the sleeve for rotating it either up or down, and then with the handle. With practice, you will know how to use some of these things. When the sleeve, for example, is up, we use the plane mirror effect, and this is what is normally used. So let us now look at the setup. To start with, you will need a very comfortable seat for you, the examiner, and your patient so that you are at the same level. Have a distant target so that the patient's eyes are in a relaxed position. And then determine your working distance. This is very crucial. It could either be half a meter, 2/3 of a meter, or sometimes 1 meter for those who are quite tall. Always use the right eye to examine the patient's right eye and then the left to examine the patient's left eye. And then start off by sweeping the patient's eye with a beam of light from the retinoscope and observe the light that comes out of his eye. As you sweep across or up and down, determine if the motion is with or against in each of the meridian. It could be a vertical meridian, horizontal, or oblique, just as necessary. Remember, the two principal meridians are separated by 90 degrees. Let us now look at the character of the reflex that you get and what this means. A dull reflex means the refractive error is high. For example, a +10 or a -10. Or otherwise, it could also mean that there are midi opacities. If a patient has a cataract, you get a dull reflex. On approaching neutrality, the speed will increase and become brighter. So you need to watch out for these things. Again, as I've just said, on observing the reflex, there are 4 likely scenarios. You may get a with movement, against, or no movement at all. or you may get a scissoring movement. So we'll discuss this much later. If you get a width movement, then use convex or plus lenses, and then if you get the against movement, use the concave or the minus lenses to come to neutralization. It's usually very difficult or very hard to work with the against movement, so just increase the minus lenses so much until you get a width movement, then start reducing the lenses until you get the neutrality. Also note that for fast movement, which means the error is very small, use smaller power steps, for example minus or plus 0.5 diopters. Then for slower motion, use greater steps because the error is big. You could probably start with plus minus 3 instead of going for smaller ones of 0.5, because then you would take a lot of time, get tired, make the patient quite tired. So be sure what you start with depending on the size or the power of the refractive error. Continue adding the power to neutralize the reflex, and then repeat the whole procedure, the whole process for the second eye. Sometimes you may get a scissoring reflex. This is when two bands of reflex appear to move towards each other or away from each other, just like the scissors. This is usually seen in keratoconus and irregular astigmatism. At this point, you must be very sure which meridian you're dealing with. You have to look for the principal meridian. We will tackle this in another video. Now let us look at the working distance. This is the distance between the retinoscope and the patient's eye. If the distance is infinite, for example, say over 6 meters, there is no need to work on the working distance. This is, however, not practically possible because it will not be possible to see the reflex, and even changing the lenses from this to this will not be practically possible. So normally we will perform retinoscopy at 0.5 meter to 2/3 of a meter depending on how tall you are. Some people could even perform at 1 meter. We have therefore to modify our calculation to take care of the working distance. So how do we make these calculations? Simply take the reciprocal of the working distance in meters, and the result will be the dioptric power equivalent to the working distance. So this is the distance that you're going to subtract. So for example, if working at 0.5 meter, which is 50 centimeters, this distance is 0.5 in meters. The reciprocal of this is 1 divided by 0.5, which is equivalent to 2 diopters. You therefore must subtract 2 diopters from the final results that you get. Before you make your final calculation, be sure to have recorded all your findings in each meridian. For spherical correction, there is no calculation except for the working distance. Whenever there is a difference in power in two principal meridians, say for example one is +3, the other one is -2, it means there is a cylindrical correction. As you do your calculations, remember to deduct for the cycloplegia. For example, if you used atropine, deduct 1 diopters. If you used homatropine, deduct 0.5 diopters. And if you used cyclopentolate, remember to deduct 0.75 diopters. I hope this lecture has helped you to understand how to perform objective refraction in a very simplified manner. Be sure to check our other related videos in the link below. And is there something that we missed out? Please point it out down here in the comments below. Or is there a topic you would want us to cover? Also let us know. Remember to hit the subscribe button to get alerts for our next videos. And until next time, goodbye.